a pleasure to welcome you to the Grand Round sponsored by the Neurodevelopmental Discovery, IDC, that I have the pleasure of co-leading with Bob Pfeiffer. Today we have the privilege of hearing from Dr. Alan Couple-Lewis. Alan is an associate professor of psychology and director of the USED at the University of Maine. I got the opportunity to hear from Alan about that endeavor last night. As he fits his position, but I think is worth stating, that means that he gets a range of impressive awards from groups including the Department of Health and Human Services. Well, I mean, he gets the USED award, but he also has a range of other impressive awards from the federal government, also the state of Maine. But as I was alluding to, Alan, from my perspective, this is not actually historically true, but from he actually got some degrees from the University of Wisconsin and so on. But from my perspective, Alan started here at Mailman in the Department of Psychology. He was invaluable to my early research because of his facility with counting and numbers more general. And perhaps we'll touch on that today. Alan has engaged in an extraordinary range of research activities. So we co-mentored some graduate students who are looking at how little babies communicate and coordinate their communication activities, their behaviors. He did a lot of work on the development of speech, both in kids with Down syndrome and kids with hearing loss. He also did a lot of work on bilingualism and related those two, deafness and bilingualism. He's also a vision researcher. He knows his way around. A lot of Alan's recent work and activities have included research on service research on individuals with disabilities throughout the lifespan. So all the way from the babies to aging folks, touching off the stops at college students and people transitioning into the workforce. But it's not only research, it's also advocacy. I think you'll get a sense of that today, but that also includes articles in the popular press, statements to the legislature on the issues that are so important to us. And today, Alan will be putting it all together and talk entitled "Using Count Data to Achieve Freedom and Equity for People with Disabilities." Won't you join with me in welcoming Alan?
Thank you, Dan. Okay, let me make sure the room Zoom looks right. Is that the view that y'all want to see? No, probably not. Should have left it the way Dan had it.
If you click on the little guy,
The little guy.
the one above the blue one, yeah, one more up.
That one. I don't think that's the one you want.
It doesn't matter, we're seeing, I see.
I think this will work. Okay, thank you for the feedback. Okay, so using count data to achieve freedom and equity for people with disabilities. So in addition to thanking Dan, I want to thank a few people. So I want to thank Bob Pfeiffer and Dan Messenger and Danny Armstrong for inviting me to do the grand rounds. It's been a pleasure. I haven't been to the University of Miami in 20 years. It's been a real pleasure to see what's happened on both the Coral Gables and medical campuses. Also thanking some of the funders who made this work possible. So the Maine Developmental Disabilities Council, I'm going to call them the Maine DD Council from here forward, if you don't mind. They funded some of the work. So I'm going to be going through two case studies today. They funded the work in the first case study. The Administration for Community Living at USDHHS. This is the core grant for the University of Maine University Center for Excellence in Developmental Disabilities. there are 67 USEDs in the United States. Mailman has a USED. State of Florida has 2 USEDs, one of which is at Mailman. Most states have 1 USED, and in Maine, the USED is at the University of Maine. In addition, so they funded the work that's in the second case study. And the third one is Maternal and Child Health Bureau. Just like Mailman has a LEND program, the University of Maine has a LEND program as well. That's a cooperative LEND program. The lead institution in the New Hampshire mainland is University of New Hampshire. And the 2 subawardees on the New Hampshire mainland are Dartmouth Geisel Medical School and the University of Maine. So they funded some of the work that we're talking about. Really, I'm after the second case study. So yeah, my first contact with the Mailman Center was as an undergraduate working on Mike Lynch's, it was before his dissertation, working on his research projects. It was in fact the first publication that I ever had. It eventually became the first publication I ever had. I was like 4th author, or perhaps even after that. So that would have been, I think, 1987. So that was over at the Debbie School. I used to, back in the 70s when I would see this show, actually mostly it was the cool kids in class who watched Welcome Back, Kotter. I watched Happy Days, but I wasn't born up for Welcome Back, Kotter. I identify with horseback. I think that today I might be Kotter. So it's been a pleasure to come back. And in addition, I do owe the University of Maine. I do that all the time. University of Maine, University of Miami. You have no idea how frequently I make that confusion. So I apologize in advance for doing it again. So I owe the University of Miami quite a bit. So this is me before I actually came to the Mailman Center. This would have been probably in '86. And that thin person right there is me. And over here is my wife, Cecilia, who was also at the University of Miami, and she is still my wife. So I will be forever grateful for that. I think this was actually at a party at Mary Wiegelman's house for the Open Door, which was a project that used to just fund the campus. I believe, from according to the webpage, that Mary is still affiliated with the psych department. So enough about me and my trip down memory lane. Let's talk about counting data and how to use counting data to achieve equity and freedom for people with disabilities. So what do I mean by counting data? What's count data? 1, 2, 3 pumpkins at a Halloween party. Oh. Counting data means you count things. Usually we measure things like with rulers or with having people take, we take observations of people, we have them fill out instruments, we measure things about their blood, various biomarkers. Counting is very simple. You count things. What do you count? You can count anything. So there are 4 examples on this slide, 2 of which come from the 2 case studies in this presentation. So number of times a baby smiles. So this is actually work that was in collaboration with Dan. That we presented at International Conference on Psychological Sciences last month. So you count number of times a baby smiles when interacting with various adults. Interacting with mom, interacting with dad, interacting with a stranger. Although usually what you actually want to know is how frequently the child counts. Well, that's just rate data, but basically what you're doing is your numerator is your count data, and your denominator is how long the video tape was running for, or how long the protocol was running for. And that might be different from child to child, but that's not something that you measure. That's something that basically is under your experimenter control. So the thing that has the error bars on it is the numerator. So the count data is like what you're basically analyzing. And this the per minute part is just a weighting factor. Another example is number of early exits from an early parent education program. So I'm the local evaluator for Educare Central Maine. Daryl Greenfield is the local evaluator for Educare in Miami. There's 24 of these Educare programs nationwide. One of the questions of interest in Educare is early Head Start, plus a lot of local money to make it really good and very data driven. One of the questions is, because it has demonstrated positive outcomes, what makes it more likely for a child to drop out of Educare prematurely? So to answer questions like that, we count the number of early exits. In fact, what we actually analyze is number of exits per year per child, turning the count into a rate. Another example, number of deaths from COVID. That's counting up to a very big number. To actually answer a research question, we typically have a denominator, number of deaths per month per capita from COVID in different populations, and how that might change over time as well. So this is from the second case that I'll be talking about today. And last, number of times a child or adolescent in a residential program is restrained. Now, of course, the census in that program can change over time, especially with COVID lockdowns. So in fact, we actually have a denominator, which is, so we have number of times per child per day. Actually, two denominators there, that a child is restrained. And the research question is whether we can lower this rate, part of achieving freedom from restraint. All right, so most of us learning statistics. Who in this room is taking statistics before? A lot of hands go up. I'm not going to ask you who has enjoyed the statistics program that you've been in. If I did, my hand would go up. I don't know how many other hands would go up. You learn about stuff with the normal curve. You learn about variance is constant. Everything's normally distributed, or you can assume so. With count data, you can't. Normal curve is nice, smooth curve. Count data. 1, 2, 3. What about 2.5 count? 1, 2, 3. Can't be normally distributed because it's like that. It's not smoothly distributed. It's like that. So yes, you can't use your typical t-test and f-test and Mailman regression, that kind of stuff that you learned about in your first class. But you can use tools that are actually pretty similar. And so a lot of the skills are actually transferable. So how do we analyze count data? ANOVA analysis of variances assumes data are normal and that they have equal variances usually. So we don't use ANOVA. Linear regression assumes your data are normal. We don't use linear regression. We use what's called Poisson regression. I have emojis in the PowerPoint that assume that Poisson is named after fish. That's the French word for fish. It's actually named after a French guy named Poisson. But let's pretend it's named after the fish. Poisson regression is a type of what's called generalized linear regression, which is why a lot of the skills transfer. And you don't have to have a fancy statistics program to do it. It's built right into SPSS and a lot of other statistics packages. So this was the screenshot from my SPSS. So you don't click on general linear model. You don't click on regression because those are the linear ones. And what you click on is generalized linear models, where you can click on log linear, which is specifically Poisson regression, where you click on generalized linear models. One of the generalizations is Poisson regression. You see, if you click on generalized linear models, you click on Poisson log linear. If you're using R, which is how I do most of my analyses, you don't use the LM function, which is for linear models. You use the GLM function for general linear models. In SPSS language, it's generalized linear models because they use general linear models for what R is called linear model. And so you just use a function called GLM. Some of the data, I think they actually use something a little more complicated called generalized additive models. I'm going to paper over that distinction for the purpose of this talk. You can email me if you have questions about it. So let's just actually start to get into one of these case studies. So restraint and seclusion.
I think you should make that small.
Like that?
Yeah.
Okay. Better?
Yeah.
Okay. Less distracting, huh? So restraint and seclusion. So here's just some examples of what it looks like when a child is restrained by adults following procedures that are endorsed by some programs. So this is what a prone hold looks like. George Floyd was subjected to a prone hold. He also had a knee on his neck for 8 minutes. Prone holds are dangerous and can lead to asphyxiation, even when there's not a knee on your neck for 8 minutes. Supine hold is the child. It doesn't have to be a child, obviously. George Floyd was a child. is on your back, basketfuls, all of these are actually put the person under restraint at risk for asphyxiation. In educational settings, restraint and seclusion are vastly disproportionately used on children with disabilities. And there's references at the end from the U.S. Department of Education and the Government Accountability Office talking about this. So it's not a disability-specific issue, but it affects kids with disabilities vastly more than kids without disabilities. There are national initiatives on reducing the use of restraint and seclusion. The federal government sees that as a civil rights issue. There are state initiatives on reducing the use of restraint and seclusion. So one example is LD 1373, which is that LD means legislative document. That's what we call it. They don't call them House Bill, Senate Bill, we call them LDs. LD 1373 passed, I think it was 2 summers ago. Among the things it did was make prone holds illegal in the state of Maine. It did not make supine holds illegal in the state of Maine. As introduced, it did. What passed was a compromise, and so the advocates let go of supine in order to ban prone. And it also put processes in place to use data to do reviews for why did this child become restrained, so that a plan could be put in place to reduce the use of restraint in the future, so it doesn't become a pattern. I was actually on the Senate floor in Maine to pass this bill in my personal capacity, because it almost didn't pass. Passed the House overwhelmingly, but it was first vote did not go well in the Senate. And so there were a few senators whose vote was in question, who were open to convincing. And I remember that several of us were on the floor talking about, several advocates were talking about, we're working the bill. And we stopped for lunch. And as we stopped for lunch, we're checking ourselves and we're like, did you see this? Paris Hilton was tweeting the names of the senators whose votes she wanted to flip to pass LD 1373. Like, Paris Hilton? We're in Maine. Does Paris Hilton know where Maine is? What I did not know at the time, but I have found out since, is that Paris Hilton is an advocate on reducing the use of restraint and seclusion, not specifically for kids with disabilities. Because she was in a residential school in Utah where it was used a lot, and she thought it was a rights violation. So to actually get to some data on case study 1. So the goal here was to see if we could reduce the rates of restraint and seclusion in residential educational programs for children with disabilities and behavioral challenges. So this was work with Alan Kurtz, recently retired from the Center for Community Inclusion and Disability Studies, with funding from Maine Youth Council. So there are a number of protocols used in this country whose goals are to make restraints safer, so children don't asphyxiate, to make it safer for the staff and to reduce their use. Promoting behavioral interventions. Safety care is an example, LAN's an example, TCI is another example. There's a number of them. So therapeutic crisis intervention. The DD Council was really interested in testing intervention called Ukero, and was looking for a provider to adopt Ukero so we could actually test it and see if it worked, because there was a lot of interest in the philosophy of it. And a number of us, the you said included, being a research, education, service and generation organization, especially on research, wanting to test the hypothesis that it was effective. Couldn't find someone who would adopt a new program. Did, however, find a program that had high rates of restraint and seclusion, that was already using TCI and didn't want to switch courses midstream, but was interested, but basically worked with the council and the USAID, which got the subcontract from the council evaluation role, to test if they could reduce the use of restraint and seclusion. So TCI is calls itself an evidence-informed crisis prevention and management system. Notice that prevention and management is down. For organizations that serve children, including residential child care, schools, and foster care, designed to reduce the need for high-risk interventions like physical restraints, aims to provide staff with skills, knowledge, and attitudes to help young people change old habits and destructive behavior, and aims to help the staff prevent the crisis, safely de-escalate, manage the crises when they do occur, reduce the need for physical restraint, and support young people's social emotional development. And so there's some tension there between safe restraint and reducing the use of restraint. There's some significant tension there. So the program was using TCI, and the team at TCI was offering a quality improvement and fidelity assessment process, what they called their TFAP. And it became published in 2022 while we were analyzing the data from our evaluation. The TCI developers implemented TFAP with an agency that serves children. It's designed to occur over about 3 months. And the program developers conduct staff surveys, conduct a 2-day site visit, they do fidelity assessments in order to gather information. They discuss the findings with the client and plan steps to improve the TCI system. It's a quality assurance, continuous quality assurance protocol. They focus on the organization leadership. I think this will become important for interpreting findings actually. Building relationships, co-learning, individualized approach, data-informed decision-making, acknowledging risk and congruence. So the methods of the study were to test if this KEEP-FAP process was effective at essentially improving the fidelity and reducing the use of restraint and seclusion. If they were already using TCI, they had high rates of restraint and seclusion. So there were 2 settings, educational and residential. The agency had multiple sites. So there were 2 schools, control group, control school, intervention school, multiple residences. So we could have control residences, intervention residences, treatment and control conditions. It was planned as a mixed methods study, where there were going to be interviews with staff. They were planned. We did not analyze it because this all happened during COVID. And few staff consented to participate due to the severe pressure of COVID. So we had data, but we didn't have enough data. So what we did is we focused on the quantitative aspect, analysis of incidents of restraint and seclusion, the counts. Most of these incidents were restraint. I say restraint isolation. I'm using the word isolation because seclusion in the residential settings in Maine is actually illegal. I believe, or against the rule, it's not against the law. And I think they had a policy not to do seclusion, but isolation was what they called it when the door was open and an adult was in the doorway. Kind of feels like seclusion to me. It wasn't technically seclusion under the rule they were offering. We agreed to call it isolation. Regardless, most of the instances were restraint. The child census varied over time. Under COVID lockdowns, they really varied. Like when the school setting locked down and some of the kids who were not residential kids didn't attend school during that time, the setting would fluctuate wildly. So we analyzed incidents per child per month. You know, so we corrected by the right denominator. Here's some results. Rates of incidents of restraint or isolation over time. So this is time from October 2019. We actually had, this is before the study started, but we had retrospective data going through August of 2021. The COVID lockdown in Maine happened about right here. The state of civil emergency happened in Maine, like in March of 2020. During this time, there were a total of over 24 incidents of restraint or isolation over these 26 months, 3.6 incidents per day. And you can see up here, we have a rub plot of ticking off the time of every single incident over time in the control educational setting, the treatment educational setting, the control residential setting, and the treatment residential setting. Rates fell over time, even in the controlled condition. There was a visit from the KEEP-FAP team at this time and at this time, and the rates were actually falling even before the visit. Well, you try to do research and applied research, and then the world intervenes. And this even happened before COVID. I know a couple things. One is the rates are much higher in the residential settings than the treatment settings. Look at here. About 1 per person per day versus about 0.2 per person per day. So 5 to 10 times higher. Also note that the error bars, the ribbons of uncertainty are wide where the counts are low, and they're more narrow where the counts are high. That's one of the things that linear regression doesn't do right. And that's one of the reasons we use Poisson regression. That is Poisson. So, instead of going into the gory details of how we use generalized additive models for this, let me just simplify the data. Because this is where the interpretations come from. Rate of incidence before versus after the first visit. Pre-post. We analyze data more sophisticated than this, but this is easy to understand. The first thing to note is that you can see the residential rates were much higher than education. The incidence declined in all settings. They went from high to low, high to low, and there was a big effect. And it wasn't the intervention that caused that big effect. The incidence declined more in the treatment conditions than in the intervention conditions. The cyan curves, the blue curves go down more than their corresponding red curves. So that's the difference between these two slopes and these two slopes. That's the intervention effect. So we can estimate, and notice, by the way, little error bars where the rates are high, big error bars where the rates are low. When there's few counts, it's hard to get a good estimate. We can calculate from this graph the number of restraints that were avoided. Technically, it's correlational data, but we can think of it as number of incidents avoided in the treatment condition. So basically, in the residential setting, essentially, if you think of the counterfactual of if the treatment condition had been controlled, you could basically you could have avoided half of the restraints. That's actually a pretty big effect. It's not easy to see it because there's this really big, secular change effect, but it's actually a really big effect. And in the educational setting, you can eliminate about 33% of the incidents. Overall, with them almost half. Pretty big effect. That seems to be like the quality improvement process was achieving freedom from restraint. So the conclusions were happy outcome. The fidelity visits were associated with a large reduction in incidents. There was this ambiguous outcome of the rate was going down in all settings. Why? My pet theory is the leadership interest in achieving the change. I think that leadership interest was, affecting the control condition as well as the treatment condition, the agency's culture. I don't know that. I don't have data to back that up because we didn't do the mixed methods part because of the pandemic, but I think that's why. It's not because of the pandemic, because we controlled for all those lockdown effects. Like we couldn't just say it that way. What's very clear is that this needs to be replicated, especially given that significant nuisance effect. It's very promising. Okay, case study 2. Equitable access to vaccines during public health crises. Oh, this shouldn't say residential education programs. Just look at the this point. So this was the one that was funded by the USIP program. So we know that age is a major risk factor for bad COVID outcomes. Y'all remember when COVID vaccines were in short supply? I sure do. Facebook reminded me a few weeks ago of when I got my first vaccine, and I was smiling from here to here because I finally got it. When COVID vaccines were in short supply, there was a time when a handful of states restricted access based solely on age. Keep it simple. Connecticut and Maine were examples of those states. And they justified the just basing on age on data analysis, which I thought was great. Disability advocates in Maine, you said Disability Rights Maine, the Maine GD Council, Maine Parent Federation, Autism Society of Maine, a lot of the disability advocates wanted kids with disabilities to be prioritized. I was kind of moderate in this discussion because I was like, no, they got data. I know that we want our population to be prioritized, but they got data. What do the data say? So we asked, what did the data say? Time for Poisson regression. You count how many COVID deaths there are. So you can quantify the age effect. So this is data that was, the numerator is downloaded from cdc.gov. The denominator is downloaded from census.gov. So states typically, the states that did this quantized the age by decade of life. First, the 80-year-olds got it, then the 70-year-olds got it, and the 60-year-olds got it, while the rest of us waited. And we could quantify how many deaths, the rate of COVID deaths. The analysis was, notice that, by the way, the error bars are wide here and narrow here. They're all really narrow because there's lots of data for information. And the analysis was COVID mortality rose at this time, it's changed over time, about 2.5-fold per decade of life. 10 years older, your risk of COVID death is basically 2.5 times higher. 20 years older, 2.5 squared is about 6.5 times higher. 30 years older, 2.5 cubed is 16-ish higher, 17-ish higher. So we can quantify this age effect. It's a big age effect. How does the age effect compare to disability risk factors? Let's use data. So here is the size of that age effect. This is, 2.5 times higher at given life. And here are the risk ratios or odds ratios for a bunch of other risk factors. Here we have risk of Down syndrome. Holy moly, 10-fold higher? That doesn't seem very equitable, does it? Intellectual developmental disability, it kind of depended on your setting. Some studies it was like 6-fold higher. ID alone might be 3-fold higher, because there's some confounding here of congregate settings. Congregate settings itself is a big risk factor. Remember when people in nursing homes were like, we're at severe risk. People in ICF and ICF IDs were also at significantly high risk, and they were prioritized before age became the only thing. But there were some disability risk factors that were higher than the age risk factor. Well, now we had data in. There was also some significant race effects. The race effects weren't even known in Maine until Black people in Maine went to the public health department and said, collect data on us, please. And then the racial disparities became evident. People with disabilities wanted data collected as well. So this was actually shared with the public health department. There was some enthusiasm to receive data. I wish I could tell you it was a good outcome. We made specific recommendations. In states rationing strictly by age, give people with Down syndrome access to vaccines at the same time as people without Down syndrome who are 10 to 20 years older. It still keeps it simple. It's not a complicated system for folks. And similar recommendations for people with ID. Those were the recommendations. At the state level, no dice. After initially responding, great, love that you're showing us data, then it was radio silence. That was disappointing. The federal government, however, shortly thereafter stepped in and opened up vaccines to everyone. All means all. And they had enough supply that, people weren't fighting over each other in line, thank goodness. So at the federal level, there was a positive outcome. There really wasn't a positive outcome at the state level. Further policy recommendations: collect the data and share the data. This one is actually not particularly well followed. There's some real interest in it at the federal level and at some state levels. So the Oregon House in 2020 passed a bill directing the Oregon Health Authority, that's the State Department of Health, to adopt rules requiring healthcare providers to collect and report to the health department data on race, ethnicity, language, and disability. Disability is not always included in DEI. During all healthcare encounters for reportable COVID conditions. Excellent outcome. We got some measurements on the numerator. When you actually look at the data dashboard, the denominator is a little bit squishy. So that's, but Oregon's, I would actually say, probably is in the forefront of doing this. So Michelle Fong, this is her picture. She is a lens trainee in the New Hampshire lens program. She's also a public health master's student at the University of Mailman. She has produced a white paper and a policy brief about what we can do to advance public health data for the purpose of advancing public health equity. Because she wanted to actually analyze some COVID data on disability, no data available. The data dashboard in Maine and most states doesn't even mention disability. People with disabilities are, in fact, the largest population with consistent health disparities. Equity is at the core of public health practice, and data equity is key to health equity. Disability gaps, disability data gaps, hide health disparities and perpetuate harmful biases. You can't address the problem if you have the data about the problem. And with it from a civil rights perspective, because disability rights is an example, is part of the civil rights movement, exclusion of people with disabilities from benefits enjoyed by other U.S. populations like just benefits of being on the data dashboard, transgresses, in Michelle's opinion, at least the spirit of the American Disabilities Act. She has a number of recommendations and hopes to see some of them adopted by the National Advisory Committee on Individuals with Development with Disabilities and Disasters. And ACL, which funds the USED and Maine and USED here, very interested in data equity, especially from a civil rights perspective. With that in mind, I just want to say that disability rights is part of the civil rights movement. So these are a couple pictures here from Disability Pride Day in Maine. I love this poster that they bring out every year, the Statue of Liberty. It might as well be FDR holding up the flame. Over here, Sarah is a member of the Maine DD Council. This is her at Disability Pride reading a poem about congratulating you on your disability. If that's not provocative. And she is being assisted by the executive director of the Disability Rights Maine. I'm not sure if it's obvious from the photo, but from all sides of disability. She has one hand. So, you know, nothing about us without us, and all means all. The disability rights movement is a part of the larger civil rights movement. And with that in mind, I did not feel like I could come to the state of Florida and not comment about marginalized populations in the state of Florida who are being actively oppressed. And that's why you have the LGBTQIA flag in the shape of Florida here, because I cannot pass without. And within the context of disability rights as civil rights and as human rights, I just note that Martin Luther King Jr. said, "Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." The equity issue in public health data in Maine was first identified by Black people, and it is still affecting people with disabilities. And we got a number of people working on it, and we still need to work on it because it's an ongoing problem among other significant ongoing, I'm going to say, atrocities. So I think that's all I got. I think at the end I got references for some of this stuff. I can distribute my slides with a lot of references. You can follow up on that.
You know what, Alan?
Yes, sir.
I had 2 incidents with law enforcement.
Yeah.
I was coming home from Miami Subs in Fort Lauderdale. I'm not coming home, I was going to Miami Subs. This cop said, "Mister, the reason why I pulled you over is because you didn't have your headlights on."
The sound on your phone is turned on.
Oh, shit. Oh, God.
Okay, we can wait.
Sorry. Okay. What happened was I was driving to Miami Subs and this cop said to me, "Mister, reason why I pulled you over is you didn't have your headlights on. The reason why, are you tired or drunk or whatever?" And I said, "Nope." I told him I was just tired and all. He said, "Would you mind following me?" And he goes on US 1. He finds a motel, pulls me in the concierge driveway. And "Mister, the reason why I pulled you over is you didn't have your headlights on. I think you were drinking and all that." He says, "Mister, I'm going to give you a sobriety test." and you're to do it. He goes like this, follow the pen with your eyes, follow the pen with your eyes. And then after that, he tells me, I'll show you, but he says like this. Walk on the straight line. Like this. And he, said, Mister. And then he said, I want you to do another one with your arms out. And then,
How did it end, Ken?
what?
How did it end?
And then he said, Mister, the reason why I am giving you a ticket because you didn't have your headlights on. Da, 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 da. He writes the ticket. Then I had to go home. My parents had to help me.
Yeah.
And then I have another incident.
Can we wait on that one? And I think there's a question in the chat. Is that okay?
Okay,
Thank you for telling us about your experience.
yeah, but there's another experience I'd like to
Maybe
tell
there'll be time
too.
for a second question.
Okay,
So, Alicia, do you wanna, is the chat a question, or I guess we can turn it over to the Zoom audience and ask if there are questions from the table, and then if there are questions from the. So are there other questions and experiences from the table? So Alan, you said you were on the legislative floor, the House floor in
Senate
your
floor,
Senate
Yeah.
floor in your capacity.
my personal capacity.
Okay,
I mean, I have testified to the legislature in my official capacity as the USED director. Because part of the mission of the USEDs, right, research, education, service, dissemination. And part of the dissemination mission under the federal act that creates the USEDs is to share data about disability with policymakers. And so I have, frequently testified to the mechanism, frequently the most effective mechanism to do that is to testify on a bill. The legislators are like, this is the bill I got in front of me, what should I do? And so tell them, according to some nonpartisan analysis, what the effect of that bill is. This was one where I was pushing so hard for a specific outcome that I was like, I'm just gonna do this one myself so I can actually have some frank conversations with people. I don't know that I had to do it that way, but that's the way it should.
I have a question. That woman that you showed the picture of that's collecting in public health, right?
Oh, yes,
That-
Michelle.
That data or what the initiative is doing through the LEND training,
Mhm.
that's fascinating to me. And is that being broadened into different states or on a federal level? Because my coworker, Hyro, and I are really interested in
Yeah.
data.
Yeah,
Disability data.
Yeah.
Being put in hospitals.
Yeah.
Because like you said, they don't track it's not part of the demographic.
yep.
When they check into a hospital
Mhm.
or when they have a health crisis. So how are you measuring people with disabilities and their health disparities?
Well, so look at the slide because she's got specific recommendations, but basically, so our LEND program, the long-term trainees, our LEND program, we're there for 1 year. So the students have a seminar, the trainers have a seminar, they have a clinical placement, they have a leadership placement. Her leadership placement was at the USED, and she was gonna analyze some COVID disparity data. And to see, quantify, how did Mainers with disabilities do compared to Americans with disabilities, compared to the appropriate control groups. And she's picked up the phone to talk to the DD agency, which does have disability data. And to talk to the public health agency. That's a different silo, man. Which is part of the problem. And she couldn't do the study. There was no data. She asked for the data, the numerator, the denominator, basically the public health agency was like, we don't got it. We can't do it. Well, they could do it. They had made a choice not to collect the data. And believe me, it wasn't because they weren't asked to collect the data. it made a choice not to collect the data. The DD agency actually had, now, for folks that were actually on the HCBS waiver, there were actually worse than data in the DD agency. I think they actually did a pretty good job of administering vaccines to that specific population. But man, they didn't really have a good data system, and they were segregated from the public health agency when asked about linking the HCBS data with the vaccine database, which is from public health records, vital statistics, different silos. And the state just made a choice, in my opinion, not to connect those databases. And the expertise on data analysis was not in the DD agency. It was in the public health agency. And they just made a choice that they had other things to do. I mean, that's just the facts. That's not the facts. That's my interpretation of the facts, but I'm sticking to it. And so she's basically saying, you've got to collect the data. You have people with disabilities who are not having the benefit of this whole public health infrastructure that you have. And so basically, we have a federal system. States get to do what they want within some constraints, but they're pretty loose constraints. Basically, the recommendations come down to things like when the states send out grants, when the feds send out grants to the states, tell them that a condition of accepting the money is doing a bunch of things, including collecting and reporting back on some of these data regarding disability. So you can actually do the analysis. That's like the big picture of what recommendations come down. The recommendations to the states for improving equity, and recommendations to the feds, specific agencies within the federal government, to induce the states to collect data to actually address that.
How does funding play into all of this for the schools, the agencies, and the departments?
There's not enough money for them to do everything they need to do. Which is why they have to make choice about what to do. And this is not a choice that most of them decided to do. I mean, when it comes down to allocate. And actually, sometimes it's not money. Sometimes it's just time. Because actually, during the COVID crisis, there actually was a lot of money sloshing around. Usually, it's money. During COVID, it actually wasn't money. It was about people's time, because people were pulled in a million different directions. Because there were, that's when they ordered the number of people who were dying in this country. But it still came down to allocation of scarce resources.
Mm-hmm.
And this was an area that there was where there was not an allocation of those scarce resources, in my opinion.
Alan, a lot of what you've talked about today are really public health policy related issues, but it seems like there's some real opportunities to use this at a level of determining inequities in terms of specific health outcomes.
Yeah.
Using large electronic health records from health systems and the like. But one of the challenges that we've had at the national level from the clinical translational science award programs is the overlay to interpreting health outcomes really involves a number of fairly significant social determinants.
Yeah.
And those data don't exist in the EHRs. What do you have you probably have given thoughts about, what would be the kind of data that would be needed from a social determinants perspective? How might that be improved and captured in an EHR to be able to do those big data sets?
I mean, if it comes to social, you can think of it as social determinants of health. You can think of it as, from an intersectional perspective, because, you've got a number of risk factors and they may have additive or super additive or potentially some additive effects. Well, I mean, right, you mentioned actually telling the hospitals to collect data on it. That's essentially what the Oregon model was doing. It wasn't just about hospitals, but it was, collect data and put it in the database. I mean, the other thing is that when you can cross-link databases, people with disabilities frequently live in a DD agency database. And they have Medicaid IDs when they're in there. And we got other databases, at the state level on vaccinations and data on various and you can frequently, it takes work, it takes allocation of time. You can actually link some of these records together, and even if it's not the EHR, you can actually, do some linkages and do some of this study, and you can at least start to collect some of these measures, so that down the line, when you actually start to collect more of the measures, you can have some longitudinal data. But you gotta start with like the basic stuff of actually collecting the disability data and getting it from the agencies that have it where it exists. Because a lot of the data is siloed. And this isn't just a disability issue, this is the big systems, get subdivided into smaller systems, and then the subsystems don't talk to each other. And sometimes they're worried about HIPAA. So one of Michelle's recommendations was saying, like, stop worrying about HIPAA. If you actually read HIPAA, what I'm proposing is actually an allowable thing to do. But there's some risk aversion. So sometimes there's a reluctance to link the data when it's actually allowable to link the data. So the risk aversion is actually still. And that's a problem with allocation of resources. It's a problem with allocation of well, I guess, legal analysis to actually verify that this actually, HIPAA does actually allow a lot of this. But people are trained not to violate people's privacy. They sometimes overcorrect from previous violations of privacy by not sharing data they actually are allowed to share.
And then some people may not want to disclose their disability if they have
Oh,
a
yeah.
visible disability.
Yeah.
And I was wondering, it may not have to do with data, but having people with disabilities classified as medically underserved, medically needy criteria, do you think that would help? Maybe that would have funding, but I don't know.
Yes.
Would help with data, trying to have that happen. right?
Yes, and I do not recall if that was one of Michelle's recommendations, but it might have been, because it is absolutely something that the disability community has been pushing for several years. And there's definitely actors at the federal level who want to see that happen, because that would actually have, that would actually make available a pot of money that's, where that's part of your deliverable to achieve that. And so that someone gets tasked with actually doing that, and then it's more likely to happen. Yes, Dan.
So I have two kind of chat related questions. So I heard that Drew had a question, and then William also has a question. I don't know if those people want to unmute and ask their questions. And I actually don't know if they unmute.
I can unmute. I might also be both people unless there's another Drew on the call. So I'm William and Drew Rothenberg. So I might have doubled up my question. But I could ask the question that I posed in the chat. Dr. Koba-Lewis, thank you so much for the presentation. It was amazing to me to hear how you're thinking about linking different state databases and kind of breaking down these silos to advocate for people with disabilities. The question I had that I was struck by as you were talking about your COVID advocacy and your team's COVID advocacy was your ability to kind of meld state level data with existing research literature. And I was interested in hearing how you kind of went about that process. Like, how did you intermingle those two things, and what did you weigh in the research literature to kind of determine this is a representative enough publication to be able to use as a piece of advocacy alongside state data? Because that just seems like such a powerful way to use both of those data sources.
So thank you for your question. So do you prefer William or Drew?
You can call me Drew. That sounds great.
Drew. I mean, it literally was, the DD network works very closely with one another. The PNA, the D Council, the USED, and Speaking Up for Us, which is the main self-advocacy organization. We meet all the time. And during COVID, there was a lot of Zoom going on during COVID. And there were people who were advocating for, like, actually going beyond this, but advocating for informal caregivers of kids to get vaccinated. And we didn't have data to back it up. It was a completely plausible thing to advocate for. I advocated for it, but it was speculative because there wasn't a lot of data about COVID in general at the beginning. So there was a lot of concern. And when the state prioritized based on age, which was actually going backwards because they had previously prioritized disability in congregate settings. And then if you went in a congregate setting, but you were served by an agency that had a congregate setting, you could like under the radar get the vaccine. There's some, I mean, there's always ways for people to get access to vaccines in some, other methods as well. But actually, I can tell you, my son, I have two sons. One has autism. And I mean, I did not see the data. So I'll get to your question in just a second, but I did not see the data on justification for him getting early vaccine. I wish I had seen it. I mean, not that I wish he was at higher risk, but I wish I had, but I mean, I was like, I can't justify it. He eventually got an early vaccine. It was privilege at work, man. This was during the time when the state was prioritized just based on age. So I had another son who was working as a behavioral health professional. He was the first person in the family to get vaccinated because he was a healthcare worker. My wife and I were older, so we got vaccinated next. My son with disability didn't get vaccinated because he was young and healthy, according to the criteria. What happened was, so the state's prioritizing by age. What happened was the medical director at the local FQHC, the local federally qualified health center, said I can get your son a vaccine. And I actually said to them, I can't ethically accept that because he's not actually at risk according to the data. And the medical director said, I know your son. I have a good idea what his body mass index is. Have you looked at the CDC criteria? And he was right. He was right. I had not actually looked at that aspect of the data. He was absolutely right. My son was at increased risk, and I didn't see it because I hadn't actually looked at that part of the data. But it wasn't part of the state criteria. And then he said, I'm an FQHC. Those criteria don't apply to me. And my son got his vaccine. Of course, part of that was based on data. Part of it was based on the fact that, the medical director at the local FQHC was a member of the same synagogue as I was. I think it was privilege in action. But to get to your point about what we did, basically there was concern about it, and it was Google Scholar. It was first of all watching the state public health director do a public presentation with data. He posted his slides, just saying I'm going to post my slides. And I said to the other advocates in the community, I'm not going out on a limb advocating for something when there's actually data that suggests that we might be wrong. And so, the USAID's role in that coalition was to do the data analysis. And so, that's why the Core Grant funded, me to basically look at the data. And then I was like, oh, we can actually quantify how big this affected. Because the state health department did a lit review. They went to Google Scholar too. And then what did I do? I went to Google Scholar. There weren't that many articles to sift through, frankly, because there wasn't a lot of data collection. There were a handful of authors that did manage to get some data from a handful of states to quantify the disability effect. And Google Scholar basically led us to the data analysis and then put together the forest plot that you saw. And that's when I said, okay, now we have something. Now we actually have data, and we're not going out on a limb to advocate for a policy change. It just came down to Google Scholar and Poisson regression.
Thank you, Drew. Thank you, Alan. I'm going to end with one more comment from the chat. Kent, I think it's Amy Robe says, so sorry that happened to you about the headline ticket story. So thank you for sharing that.
You're welcome.